So welcome to this edition of the Perspective in Inflammation podcast, a series brought to you by the CESF, which shines a spotlight onto experts in the field of inflammation. So I'm Professor Pierre Miossec from the hospital Édouard Herriot, located in Lyon, France. And with me are my fellow CESF steering committee members, Professor Tsutomu Takeuchi from Keio University and Professor Christopher Ritchlin from the University of Rochester Medical Center. So we'll be discussing the relationship between radiographic progression and clinical disease activity in patients with psoriatic arthritis. But first, I would like to understand more about your life and how you have been brought to the field of rheumatology.
Yes, Dr. Miossec. My interest in rheumatology began with a real strong interest in immunology, which at the time when I was thinking about a career was really starting to gain a lot of momentum in terms of the interactions of immune cells and how they participated in inflammation in the joint and other areas, and also by the ability that rheumatology allows me to not only apply the analytic skills, but also actually examine and interact with patients over the long term. So those two together really led me into the field.
And where did you start it?
I did my training in internal medicine at Mount Sinai School of Medicine in Manhattan, and then did my training in rheumatology at NYU, New York University Medical Center. I was in the lab of Robert Winchester, where we were studying the shared
My good friend Robert.
Yes, I trained. He was my mentor.
Oh, really? Yeah, small world again.
Yes.
So, and then you move, I guess, where you are now, right?
I was in Montreal with Robin Poole.
And French speaking then?
Yes, yeah, and then I moved to Rochester, where I've been since the early 90s.
Yeah. And now your focus is there?
So my focus was initially in rheumatoid arthritis, where we were studying synovial biology many years ago, but I switched to the study of psoriatic arthritis probably about 25 years ago, and we first began our investigations into the synovial tissue, but rapidly then I moved on to trying to understand what's happening in the bone in patients with psoriatic arthritis. And so that is now the focus of my laboratory, where we also work on biomarkers of disease activity and markers that might let us know which patients with psoriasis will develop psoriatic arthritis.
And to say more on those?
So in terms of, as you know, the really fascinating part of psoriatic arthritis is that you have this very aggressive bone loss phenotype coupled with new bone formation. And that occurs in both the peripheral joint and also in the axial skeleton. So, and work that you've done illustrating how important the Th17 pathway is in that area is something we've picked up on and we study very intensely, as well as trying to gain a better understanding of what are the elements that to determine this bone dysregulation and remodeling.
Okay, yeah. Well, that remains a key question, right? To understand the differences in the single joint having construction and destruction.
Absolutely.
Yeah. And how do you see the dynamics of these events? I mean, the early phase compared to the later stages of this disease?
Yeah, so I think that what's really intriguing is that if you look at the bone of patients with psoriatic arthritis, if you look in the distal radius, you see a tremendous loss of trabecular bone, but not cortical bone, which is very different from rheumatoid arthritis, where you see both cortical and trabecular bone. If you look at a psoriasis patient, on the other hand, you look at their distal bone, you don't see a loss of the trabecular bone or the cortical bone, but you see these enthesophytes, which are out in the outer bone. And I think what's really fascinating is that there is a bone phenotype in psoriasis, even though they're asymptomatic, but it's very different than what you see in the actual arthritis. What you see in the early stages, of course, are focal erosions and enthesophytes. And in later stages, you can see either extensive degradation of bone or even fusion with ankylosis. And that's what makes this so fascinating, is this mixture and heterogeneity of the bone phenotypes.
And what could be the sort of biomarkers, easy to detect biomarkers to sort of, I can't say predict, but at least to identify these different subsets and very different in terms of mechanism?
Oh, absolutely. So one of the things we focused on many years ago was something called osteoclast precursors. These are monocytes that are destined to become osteoclasts, and you have to do this through some in vitro assays you know well. And we've been looking at markers on these cells. One of them is called DC stamp, which is a molecule required for cell-cell fusion, which marks osteoclast precursors. CD14, CD16 is another marker. But these are cellular markers you need to get to by flow cytometry. And we're all desperately seeking a marker in the serum that will help us to find these this kind of risk. But so far, we just haven't been successful in that.
Yeah. And I guess you are collecting samples to be ready one day to use them with new markers.
Yeah, so we have a very large registry with Daphne Glavin in Toronto, Canada, and J.T. Elder at the University of Michigan. We have about 8,000 psoriasis and psoriatic arthritis patients who are extremely well phenotyped, and we have extensive biobanking samples on them. So yes, we're ready.
Yeah.
Show me the molecule.
Yeah, okay, great.
Looking forward, are there any upcoming developments in this area that our listeners should be aware of?
So I think that the developments in the field of spondyloarthritis are many. This is a very hot field right now. I know that there are many abstracts at this meeting looking at the JAK-STAT inhibitors and their ability to influence bone destruction. And so we'll be learning more about that, both the JAK1 inhibitors and the JAK-TYK2 combination, as well as molecules that an antibody in particular that actually interacts with IL-17A and F, bimekizumab, and then the idea that some practitioners are going to combinations of medications, such as apremilast with other biologics. So I think all three of those areas are exciting advancements which may help us to better understand the mechanisms that drive the abnormal bone loss and formation, and may actually provide more effective therapies. At least we're hopeful.
And speaking about the targets, such as IL-23, anti-IL-23 is working on PSA, however, not in AS. There is some distinction between two diseases. Is that one topic?
So this was a surprise for all of us that IL-23 blockade was not effective for axial disease. And it's really caused many of us to go back to our laboratories and ask a number of new questions, such as whether or not cells in the axial skeleton express IL-23 receptor, whether or not these cells are becoming activated and promoting bone by different alternative mechanisms outside of IL-23, hedgehog pathway, or many other types of signaling, Wnt signaling, and we just don't know the answer now. It's what makes it, keeps us on our toes and makes it very fascinating.
It's
troubling sometimes.
Thank you.
Well, thank you very much for your time, and I guess this topic will be a good reason for you to come back another day. So I hope you listening to this podcast and enjoy very much the discussion. Don't forget to subscribe to the CSF and get easy access, free access to education materials, so slides and others. And welcome again to this website. Thank you.